لا يمكن يكون فيها حاجه ليا.
Okay. Yeah, fine. Please mute.
بسم الله الرحمن الرحيم. ريدي دكتور ألماس؟ ريدي؟ اوكي. بسم الله الرحمن الرحيم. هنبتدي السيمبوزيوم. السيمبوزيوم ده سبونسرد بشركة الحكمة، والحقيقة شركة الحكمة من الشركات القوية اللي هي عاملة سبورت جامد قوي للمؤتمر، وبعدين هي سبورت لكل الميديكال والاكتيفيتيز اللي بتقوم بيها الجمعية المصرية للطب النفسي. حقيقة يعني من الشركات المتعاونة جدا، سواء في الافكتفنس والافيكاسي بتاع الادويه بتاعتها، او في الميديكال بروجرامز والميديكال تريننجز اللي بتعمل له سبورت. بنشكر جدا الدكتور حازم السي او للشركه، والدكتوره تماني من الاردن. بنشكر الدكتور مصطفى حجازي والدكتور سيد اشرف من مصر. الحقيقه يعني من الناس اللي احنا بنعتز بصداقتهم وبنعتز بوجودهم معانا دايما. وكنا من اسبوع معاهم في الغردقه، الحقيقه كانوا عاملين ميتنج ناجح جدا وجميل. وساعتها انا قلت للدكتور حازم طول ما انت معاك الفراوده دول يعني ما تقلقش، لان فعلا هم عاملين سبورت جامد قوي للشركه بتاعتهم، وفعلا احنا بنحبهم بنحب نتعاون معاهم. We have the honor to introduce one of the eminent lecturer in the world, Professor Elmars Rancans. Professor Elmars Rancans is the head of department in the Department of Information, Education and International Affairs in Latvia. He is psychiatrist. He is a member of editorial board of Annals of General Psychiatry, Biological Psychiatry, and Psychopharmacological Review of Psychiatry. He is assistant professor in Department of Psychiatry and Narcology in Faculty of Medicine. He is also advisory of mental health program in Foundation Latvia. He is a national focal point for Latvia. He is scientific advisor in unit of suicidology. He is peer reviewer of many of the journals, and he is associate professor in Department of Psychiatry and Oncology in Faculty of Medicine in Riga Students University. Welcome, Dr. Elmars, and we shall enjoy his lecture about an experiment in Reagla. Welcome, Dr.
Hello, hope you can hear me well. Dear colleagues, distinguished chairpersons, it's my great pleasure and honor to be invited to this event and share with you some of my clinical experience and knowledge about the use of cariprazine. So can I have my slides? Okay, still a moment. Yeah, that is okay. Here they are. So, yeah, what I'm going to tell you over the next 25-30 minutes to share what we can expect from one of the medications available in your region, in your country, for the treatment of schizophrenia. But before starting this journey, I would like to share you a little of the personal one. Would you believe, 32 years ago was my first time in Egypt. I don't know, would you hardly recognize who was the guys who standing in front of the Giza? Yeah, and right in the middle, that was me. As a young student of fifth year medical studies, I was attending international meeting of Association of Medical the Student Federation. It was a big event, one of my lifetime journeys. I had the pleasure to your colleagues sharing my story, but it will take almost a half an hour to tell all the nuances and nice things I experienced and what I went through in my previous visit. But that's not the goal of my talk today. First of all, like in any conference, I have to disclose my possible relationship with the industry, and as you see, all the industries which have been working actively in Latvia are also being part of the Speak Bureau or any other collaboration. And the same, I have to disclose that opinions expressed during this presentation is of my own, and maybe some of the indications or labels of use of medications maybe not correspond to how this medication is licensed or described in SPC in your home countries. What to start with? The first, that we have to understand how our armamentarium works in schizophrenia. And thanks to our colleagues like Hunt and colleagues, a couple of years ago they made the largest network meta-analysis looking at all the possible antipsychotics used in the clinical practice over the decades. And they started with 54,000 articles, 400 studies, more than 50,000 of patients, the data which was available to 1990. What this meta-analysis helps and gives us a possibility and opportunity, even if two medications haven't been compared each to other, but this system, this new statistical approach, can help us to see what one or other medication can do in real clinical practice. I'm not going to kill you with these busy slides, pinpointing, and you don't have to read all the small details, but you can, by the glimpse of eye, see that if you look on overall change of symptoms, both positive, negative, and depressive symptoms, you see that medication, first of all, the most important message, medication works better than placebo across the spectrum of many symptoms. On the other hand, there's no one single medication which beats and covers all the symptom spectrums, and you have to look into the nuances of each particular medication to find the best possible use of it. And it relates not only to clinical efficacy, but also side effect profile, which is important. Because efficacy, okay, it's fine, we see symptoms improving, but our patients, they pay the price with side effects if medication is not well tolerated. And among all those others, you can find and see that it is different. What about cariprazine? Medication you have been familiar for 4 years, and this, if you look comparing to other medications, it is unique. It's unique with this high affinity to D2, which is a cornerstone of antipsychotic therapy, what we have been using today, but the partial agonist to D3 receptors, this is something, a new story, with which this medication sticks out of the bunch of other dopamine modulators like aripiprazole, brexpiprazole, and so on. On the other hand, what is good story, and that's what you can see on low affinity, those receptors which are troublesome, like histamine-ergic, adrenergic, muscarine-ergic receptors, which cause side effects, they are not so pronounced if you look on the receptor binding profile of cariprazine. What we were trying to understand through these receptor symptom profiles, both symptom domains, each of these receptors can tackle, and side effects. And as you see, both dopamine, serotonin receptor system, each of them plays a certain role. And we can make a good use of it if we know how to use them. So what I was trying to analyze, and first of all looking, comparing to placebo, do cariprazine work better in general? And answer is very quick and simple. Definitely yes, otherwise we will be not talking about this medication today. It would not pass the hurdles of registration, starting from United States, EMEA, and also in your countries. And these are the 3 pivotal registration studies, which are of the similar design, we had different arms, and also these studies use active control. You know what does active control means? It's essential to prove is study correctly designed that we can rely on conclusions, what is done from that study. Because first of all, opening result of the study, like in the first study from Durham 2014, you have a look, is risperidone separating from placebo as it's supposed to be? And if it does, only then you look, is cariprazine separating from placebo? If risperidone would not be separating from placebo, there's some problems with the design of the study. On taking into account that all these studies are similar in design, what was possible to do to pull these results together. And as a clinicians, we observe our patients, we have our own system how we classify the symptoms. But the golden standard in research and clinics which are more involved in research are PAN scale. And already a while, I think already Marder factors, almost 30 years ago, when they started to postulate by Marder, all these 30 items you can divide in so-called 5 factors. Negative symptoms, which has 7 items, positive symptoms, which has 8 items, and hostility, 7 items. For uncontrolled hostility, excitement, and anxiety and depression, there are 4 items. For disorganized thought is 7. And based on these subdomains, you can look and analyze results. So, if you look on overall symptoms, you see that cariprazine nicely separating from placebo across the board, and also if you look on dose range. Okay, fine, medication registered, but what is important for us as a clinician? Look much more into the details. And here comes the difference. Those of you who have been involved in statistical clinical trials know that it's so difficult to separate from placebo results, and you need a large number of patients to show separation in one single factor. But now this result divides in 7 or 8 subdomains, and then look, do this symptom response. And what's nice, if you see on the positive symptoms, out of 8 subdomains, in 6, it's statistically significant separation from placebo. That's the good news. If you look on negative symptoms, the picture is even better. All those of you who work with a patient with negative symptoms, who wanted to see a little emotional effect being not so blunted, not being patient emotionally withdraw, being able to communicate with you better and more fluently, yes, you see separation in 6 of these 7 subdomains. What about an intriguing study? I think all over the world people have heard about it. It's an Emmett study on cariprazine in negative symptoms. What is special about this study? First of all, the design of this study. Because there was, for decades, a confusion how you study negative symptoms. What do you consider in negative symptoms? Persistent, predominant, prevailing, and so on and so on. A lot of confusions. In the design of this study, they decided to specially kind of formulate what are predominant, persistent negative symptoms. It's not only that they do exist, but they are stable for a certain period of time. And it's becoming, the design of the study becoming as the golden standard for any further studies. And plus, this study was designed as non-inferiority study. What does this mean? I just remind the audience. Non-inferiority, willing to say, we are work as good as the comparator, as good as. Does not necessarily mean better than. If you are priori as good as, that it could be, if medication A works like this, I can be a little better, a little worse, but there are no statistical difference. And this is how statistics are calculated, how many patients you need. Okay, they did, and the data, which was looked across all the different symptoms, were thoroughly analyzed, and they finally observed this one. And this is surprise and the shock at the same time. No one expected statistically significant separation between 2 active compounds on negative symptoms. And this started from week 14 onwards. This is where the Professor Nemetz, who is a father of this molecule, was, I think, he didn't even dream in his dreams that this one day might happen. Yeah, that something is happening in the treatment of patients, something represents unique, that this separation took place. If you look on the items, especially on these negative symptoms, you see that this difference between cariprazine and risperidone came on several domains. Not just the sum of it, but on several ones out of this list, which is a good thing. And that's very rarely observed phenomenon. What about our experience? When this medication became available in Latvia, I convinced my colleagues and also Gedeon Richter, we have to observe our everyday life using this medication as systematic as possible. And we designed open label, flexible dose 16-week study where we just ask doctors, if patient is not responding well to previous medication, if patient is having side effects or willing to switch a therapy, why don't we give a try? And according to existing information of that time, starting from 1.5 milligrams dosage, within 2 weeks, seeing can we switch from existing combination of medication to cariprazine, observe some improvements of efficacy or not. And then we measured very simple, using CGI severity and CGI improvement scales, and also we looked on subdomains of negative symptoms that is lately been agreed by international consensus of 5 symptom domains. What did we observe? And these are results over a 16-week period. The red line, it's a positive symptoms. And you see there is no kind of large improvement. Why? Because those patients who were included in the study were not having significant positive symptoms. But if you look what symptoms responded very well over this course of treatment, these were negative symptoms, because this was a bit more focused on our study, and up to date, this is the largest naturalistic observational studies which published these results. We haven't been exactly replicated, but the case reports, case series, some other studies in general show in the real life the same tendencies. The medication is working. What else? What else is of our interest? It's the cognitive symptoms, because cognition is essential part for the life and rehabilitation of our patients and how they can, after being acutely ill, get back to the society and work better. So it works on cognitive symptoms, and this also, if you compare it with risperidone, which in the early days also made the studies with improvement of cognitive function, in this case, you see that there is something we maybe not fully understand from mechanistic point of view, but most of the clinical observation, it works also on cognitive symptoms. What about this pooled analysis from these 3 studies? If you look on this factor of disorganized thoughts, and if you look on this data, you see across the board all symptoms which are associated in PANS with a cognition, statistically significantly better improves than it can be with placebo. And this is something else what we could learn from these data. Affective symptoms. You know, in a clinical reality, yes, schizophrenia, major depressive disorder, it should be, as postulated by Kraepelin, put on opposite ends of the spectrum. We don't diagnose this, to diagnose in single patient if they're not schizoaffective, but quite commonly we do observe affective symptoms in the clinical picture of our schizophrenia patient, especially when they start to remit from acute psychotic episodes. Can we rely on efficacy on those domains as well? And these results from pooled analysis again bring you the same picture. If you look both anxiety, tension, depression, there is statistical significant separation. That's something what can be useful in your everyday clinical practice. What about hostility? a tricky thing, yeah, because hostility, it's sometimes associated with acute symptoms on e-patients, but also sometimes it's part of excitement. The patient's hostility is external expression of the inner dissatisfaction, and this can be both in acute patients, but also in outpatients. What about this one? What about impulsivity? And what about uncooperativeness? Excitement. Yes, and here comes the data that there is something which can be helpful if you look from that perspective. What else? If you look how these symptoms improve, it's not short-term effect. It's not only just the first week. It's not non-specific sedation, what we commonly observe or we use when we use other medications. If somebody is acute, you give something sedating or the antipsychotic or some of the antipsychotics with sedative properties, and as long as it's sedating, it helps. Now, this is something different, and if patient has these symptoms, you see improvement over the course of the weeks. It goes and helps patient in the long run. What about other things? I have to start with, it's not working, it's not yet in your country. But why I want to share with you this slide? Because I'm coming from the Europe, and you see these are the medications which are available. And here you see approved indications of the studies where medications have been used, and USA, as always, are the leaders. And if you look on cariprazine, this has been approved as a clinical indication across additional spectrum of disorders. And some of them is add-on therapy. In some other cases, it is like monotherapy. If this indication have been approved, that means this supported by the studies, that there is something in this medication what we can look forward, build up our clinical experience, and as we discuss up with our distinguished chairpersons before the meeting, we have to think, look into the details and try to learn each from other. What is the best way, what this medication can give to our patients. Then safety. Yes, one of the things when you think about using of cariprazine, I've heard in other countries and also from my colleagues, yeah, akathisia is sometimes there. What shall we do? How we should treat it, how we should first of all approach. And the things start from acknowledging, not hiding from ourselves that this might be, not in every patient, and then look on clinical scenario, why these things happen. If you look on acute studies of these analysis of 8 phase 2, phase 3 studies pulled together, why I'm showing this data? Because it's a large number. It's almost 700 patients on placebo, more than 2,000 patients on different dosages of cariprazine. Yes, if you look, which are the most common, yeah, you see akathisia, insomnia, headaches would be most common. You see some pattern of dose dependent, maybe increase, but what is also important to see, what sort of and how severe akathisia was observed. And half of those cases are mild ones. Okay, what shall we do? Akathisia, how we can handle? And things start from the doctor. If you got scared and you start to panic, the patient mimics your reaction and responds the same way. If you confidently say, inform them, in some rare cases or in some patients you might observe akathisia, what shall we do? First of all, clearly see what group of patients. If the patient is more acute, maybe fast acceleration of dose will not be a problem. If someone with negative symptoms, don't rush with the dose. Don't rush and build up slowly. Because if you look on this pooled analysis, on all of these, both akathisia have been treated with EPS medication or down titration. And it takes usually a week or two, and you can handle this problem. That is what's important, and I would like to share you this message. What else? Recent review looked how we can handle. What are the tools which is available for us? First of all, slower up titration, dose reduction, just getting, not withdrawing medication completely, but just getting a step back and look. important is switching strategy. I don't have time to go into the details, but depending on the previous antipsychotic medication, you have to wait for a much longer period of time, depending, especially olanzapine, clozapine, quetiapine. If you switch from those medications, transition from one medication to another. If you want some medication which can help, benzos works well, propranolol, and some of these sedating antidepressants, which sometimes could be helpful for the patient for induction of sleep, could be useful also for decreasing akathisia. But if patient is not tolerating, definitely stopping medication, cariprazine, is one of the options. But bear in mind those equivalents of medications, because sometimes we face the problems if we forgot how these medications match each other, both from clinical perspective, but also from side effect profile. Imagine how these rough figures compare. If you look, cariprazine is equal to one tablet, 1.5, equal to 5 milligrams olanzapine, meaning 6 milligrams equal to 20 milligrams of olanzapine. And sometimes in clinical practice, I don't know how it's in your countries, if patient is severe, we go beyond 20. Sometimes 30, sometimes 40. And before saying, okay, this medication doesn't work, he was on 30 milligrams of olanzapine, you have to give adequate dosage of cariprazine or any other medication. So this is just the figures for you kind of keep in mind when you're dealing with different doses of medications. Because if you look on symptom profile, there's a certain dose response curve. If you look on negative symptoms, you'll get the most benefit at middle dose, maybe lower dosage. Not always 6 milligrams will help. On the contrary, if you want to treat positive symptoms, you have to give a decent dosage, because 95% efficacy on positive symptoms will be if you go high enough. It means something around 6 milligrams. Okay. What about polypharmacy? I teach my residents, we try to go monotherapy as long as we can, and if it's possible. However, real life, and that's what we saw also in our clinical trial, when we tried to switch from one medication to another, more than 50% of our patients in our sample was on 2 antipsychotics. And this is what we have to account into. But if you still, for certain reasons, decide to go for polypharmacy, bear in mind receptor binding profiles. And don't mix medications which are pretty similar in receptor binding profiles. These are the suggestions. If you still consider to combining something, go for these combinations. But these combinations, on contrary, should be avoided, because as you see already from the picture, they look too much alike. And cariprazine is not maybe good to combine with risperidone, haloperidol, even aripiprazole, because then we're getting something which is not so unique as we might expect in the first glance. Okay, what I was trying to cover over this last half an hour. First of all, the good thing we should really be confident about, our medication works. It's not a placebo in schizophrenia patients. If you think about cariprazine, studies and also clinical experience tells us that they are covering quite a spectrum of symptoms. Additionally, the hope now starts to appear about the negative symptoms. We definitely accumulated data, observations. We are trying to understand the best possible way how it is happening, but there is some hope that they might respond these negative symptoms well to cariprazine. In general, this medication is well tolerated. I haven't spoken in details about the side effect profiles, but it's weight neutral, prolactin neutral, which is crucial, especially for women, for young patients. And dose selection and switching strategy is the key for success of treatment with this medication. Thank you very much for your attention.